This talk continues on our resuscitation series and looks in detail at the physiology of fluids in shock states and intends to answer the question, does my patient need a fluid bolus? This will explore the role of fluids in resuscitation, as well as various monitoring modalities that might help you decide whether you need to give fluids or not, and some of the judgment that also comes into consideration. Mainly, is the patient fluid intolerant, or can they tolerate more fluid? I guess no talk on fluids is not complete without considering the various types of fluids that are available. There are crystalloids, which consist of normal saline in one camp and balanced crystalloids in others, such as normal-sol lactated Regner's solution. And there are various colloids that are out there. There's albumin and less so hydroxyethyl starch. And so we can kind of simplify this in a couple of ways, and that is that typically we try to avoid normal saline unless there are electrolyte abnormalities that suggest a very specific need to replete sodium or chloride stores. Various retrospective analyses have shown that fluids that have high concentrations of the chloride anion have worse outcomes for renal function. There has been a randomized study since then that has kind of called that into question, but nonetheless, balanced crystalloids reflect the normal concentrations of electrolytes a little bit more closely than normal saline, and so we generally try to go with that. Hydroxyethyl starch has been implicated in some coagulopathies, and some of the original research on that has been questioned as far as the integrity, and so really we do avoid that. In fact, that might have been banned by various regulatory bodies. So it's usually kind of a decision between crystalloids and albumin. Albumin and crystalloids really are kind of a wash as far as which better than the other. In traumatic brain injury, there is definitely a signal toward mortality in albumin, so that is avoided. However, other people like to use albumin thinking it will require less crystalloids. A lot of that's based on concepts of partition of albumin within the within the intravascular space. Then a lot of times in critical illness, that barrier is dissolved, and so it's going to just go into the interstitium anyway. So really, this is kind of degenerates into tribal rights as far as what you do, and so you're probably going to be more subject to local protocols and traditions than pure science. But personally, I like balanced crystalloids, especially when the amount of fluid infused is in the 3 liters, slightly more range or less. At some point, people are tired of giving large volumes of crystalloids, and so balance that out with a little bit of albumin. But really, due to cost concerns, where albumin is way higher priced than balanced crystalloids, especially in the U.S., generally try to avoid albumin. To continue along the path taken in other talks, we're assuming that the starting point is a patient with a problem, either with an imbalance between the demand for oxygen and supply, which are broken down into these crude terms, or a problem with the ability of blood pressure to support the autoregulatory range for organ blood flow in the patient. The role of fluids is to support cardiac output, and the nice thing about that is whatever you do to support cardiac output will get you moving in the correct direction from the area of risk to the area of salvation on both of these curves. And obviously fluids, via the Frank-Starling mechanism, is probably the most benign, non-rhythmogenic way of improving cardiac output as long as the patient can tolerate fluids. As mentioned in the prior slide, the role of fluids is to support cardiac output, which has an impact of both improving oxygen delivery and blood pressure. 3 Starling curves are shown here. One is someone with relative ventricular failure, one is kind of a middle ground patient, and the other one has pretty dynamic ventricular function. In all these cases, a change in preload will increase the cardiac output. However, fluid responsiveness is mainly restricted to those situations where a little bit of increase in preload will create a more exaggerated increase in cardiac output and hence blood pressure and oxygen delivery. Where that point is, where you stop giving fluids, is kind of a matter of conjecture, but various monitoring schemes that we talk about will help support the decisions on when to give fluids and when to think about other things to improve blood pressure and oxygen delivery. So this is a list of various monitoring options that might drive you toward thinking that your patient is either dry or fluid replete. There is the PA catheter, which allows you to actually generate Starling curves if you think you can do that. Often in critical illness, they're all pretty kind of flat, but you can follow the PA diastolic or the wedge pressure or the CVP with the PA catheter in place. The CVP line can give you CVP values as well. There's various various findings on echo that can help you. You can, if your ventricles are empty, that gives you a pretty good idea where the fluids are or not. And also IVC diameter, or more rigorously, IVC distensibility indices have been associated with fluid responsiveness. You can raise the legs of your patient, and especially in concert with an arterial line where you can see the instant response. That often tells you what you can do, what kind of blood pressures you can achieve with fluids. You can always examine your patient. Some people make decisions based on that, and some just give fluids if it looks like the clinical situation calls for that. There are other modalities as well, pulse pressure variability, systolic pressure variability, and esophageal Doppler and variability of respiration thereof have all been used to approach this issue. A lot of this depends on whether your patient is intubated or not, whether kind of technologies are around. So it's good to have some sense of all these and how you can use them in a more flexible manner. So what monitoring systems are the best in terms of deciding whether to give patients fluid or not? Clinical practice certainly favors examining your patient, and if the clinical history suggests dehydration or hypovolemia, giving fluids is not obviously a very rational place to start. There might be situations where as part of a surgical operation you're going to put invasive lines in, so certainly being able to use these as part of your decision making is favorable. The use of transesophageal echo is obviously easier in an intubated patient, as well as esophageal Doppler. And those with arterial lines avail themselves to analyzing systolic pressure as a way of deciding whether the patient is hypovolemic or not. And the availability of echo is increasing, and that also becomes a modality for assessing fluid status in patients where echo windows are available. So the key thing is being able to use all of these different types of tools in a flexible manner. But is there a quote best one? Well, it turns out to be that the patients who are intubated, as long as you're ventilating them in a controlled manner with tidal volumes that are 8 mils per kg greater, looking at arterial line variation turns out to have a very high predictive value for determining someone who has fluid responsiveness. I'll diagram how that actually works, but generally greater than 12.5 millimeters in systolic pressure variation is associated with fluid responsiveness. For non-intubated ventilated patients and those who are not having don't have leg fractures or anything like that, passive leg raising and assessing the blood pressure response is probably the best method in that population. And this is facilitated quite nicely with the use of arterial lines, so these are not mutually exclusive. From the prior slide, you could probably appreciate the fact that the list of monitoring modalities contain techniques that you can consider static measurements where you're getting single point values at a given time versus dynamic measurements where you're looking at loading conditions of the heart in a live manner and looking at its response to fluids. It turns out to be that these are the most superior methods. However, over time, you can inform yourself a little bit about the CVP in relationship to blood pressure, as well as some of these other measurements too, and these can actually turn into dynamic measurements. For example, if you've had kind of dips and troughs over a 12-hour period in blood pressure, and I'll just diagram it as like a mean pressure from our arterial line with blue, and during that time, that tracks CVPs quite carefully. And so this might be 0 CVP, and this might be something like 8. Then the correspondence of these two look pretty close, and one can probably make some pretty good assumptions as the CVP starts to drop that might actually be a low part of somebody's Starling curve, and then actually bringing it back up to 8 or near there would actually be more like a euvolemic state. So don't write these off right off the bat. Single measurements are not very useful, but their correspondence to other measurements that are made over time can actually be quite useful. And looking at dynamic measurements, we'll talk about those in a couple seconds, but these tend to fall into two different categories. One is just, straight loading, and I guess you could put a fluid bolus in there as well. And these are based on cardiopulmonary reactions. The basis of some of the cardiopulmonary interactions can be diagrammed. So we'll give kind of a hypothetical example here. Let's just say this is the patient's blood pressure, and this is a compressed arterial line tracing. So no breath is going in and out of this patient at this time. But right here, we're going to deliver a positive pressure breath. And so the first thing that's going to happen is the blood that's within the pulmonary circulation is going to get kind of squeezed by air entering the lungs, and it's going to take the path of least resistance, which is going to go into the left atrium. And so if the patient is fluid responsive, as soon as that breath goes in, what you're going to see is the impact of increased venous return to the left heart. At the same time that breath is going in and squeezing blood that's within the pulmonary circulation toward the left ventricle, that pressure is also creating a decrease in venous return to the right ventricle. And so a few heartbeats later, what you're going to see is the impact of depriving the patient of preload, where you get decreases in amplitudes of the arterial tracing. So this component of systolic pressure variability is very imaginatively called delta up. And this one, this departure from baseline going down, is delta down. And the total is systolic pressure variation. And when that is greater than 12.5 millimeters mercury, in studies that have looked at this, that has been associated with patients that are fluid responsive. And so what's going on in the Starling curve is the following. You have the Starling curve like so, and we're going to just describe actually it's a little too steep to describe a fluid responsive patient like so. And what you see is when that extra bit of preload is heading to the left ventricle, that little change in preload is having a very dramatic upswing in the cardiac output. And also the deprivation of fluids, that little bit of deprivation of fluids is also having an appreciable change in cardiac output on the other end of the breath. And so really patients who are very fluid responsive and where small changes in fluid have significant changes in cardiac output, you see pretty big swings up and down this kind of curve, and you'll see the same thing on an arterial line tracing. Esophageal Doppler is largely cut out of the same cloth, and what you're looking at there is basically changes in the amplitude of the Doppler signal. The integral of this waveform is called flow time, and what's reported is kind of a beat-to-beat corrected value for flow time called FTC, or flow time corrected. And what's considered to be fluid responsive is a 10% change in the amplitude of the corrected flow time. And largely that's telling the same story, systolic pressure variation. So if you figure that patient's systolic is say 125 millimeters mercury, 10% fluid is going to be about 12 administration. And that's roughly what. Well, my favorite is just look at the heart and see if it's empty or not. And so this often yields some important diagnostic information. So This might be somebody here, if you have the papillary muscles crash into one another and looks like the right ventricle is nice and empty. That's somebody who sure as heck seems hypovolemic to me. And the question is, well, where's the, what was the nature of the fluid losses? Are they bleeding or what's going on? But this is someone who will likely, when given fluid, have a much better blood pressure and oxygen delivery. The other reason to look at the echo is sometimes there's other important diagnostic information that can be gained from it. So in contrast to this patient here, this patient with a grossly enlarged right ventricle and no blood getting to the left ventricle is also often associated with a pulmonary embolus or a pulmonary hypertensive crisis where the RV has failed and it cannot pump, or primary RV failure. So analyzing the IVC distensibility is going to take on the following form. You're going to get a subcostal view of the inferior vena cava, which is going to look something like this, where this is caval atrial junction with the right atrium here and the vena cava going along like that with the liver and its various vessels occupying the near space. You're going to use M mode to visualize the vena cava a few centimeters away from the caval atrial junction, and your display is then going to show the cava as it expands and contracts throughout the respiratory cycle. And so what people commonly do is look at the caval dimension and see in its widest, is this greater than 2 centimeters? And during the narrowing phase of the respiratory cycle, kind of leaving that as a general term because it depends if it's controlled or spontaneous ventilation, if this collapses to about 50% or greater than the baseline value, then that's usually somebody who's considered to be fluid responsive. A more formal calculation is the IVC distensibility index, which is, I've got to bring it down here, sorry about that, is going to be the large component, we're going to call that large, minus small over small. And in this case, the number is a little bit different than this 50% and 2 centimeters, and that is if it's greater than 18%, that's usually in adult patients considered to be a value that is associated with fluid responsiveness. So I wish the world was as simple as what I just presented, which sounds like that your goal is to figure out whether the patient is fluid responsive, and if so, go ahead and give some fluid. And while that certainly is some thought that has to go through your mind, especially when you're trying to resuscitate a patient and trying to improve their cardiac output, at the same time you have to consider whether they're actually fluid tolerant. And as you give more and more fluid, a patient might not tolerate those subsequent boluses, even though the startling curves might suggest that that's the road to salvation. And there's pretty familiar examples that you might have run into where overloading of the pulmonary circulation, especially in ARDS, or in patients where they have poor cardiac function, where subsequent fluid might tip them over into pulmonary edema. And those are patients where somebody certainly is fluid intolerant. Probably the patient with pulmonary edema is not going to be fluid responsive, but just to give you an idea, you have to think about, will the patient tolerate more fluid? In general, with lung surgery, that we try to limit fluids to 1.5 liters in the perioperative period. Other examples are patients who have bowel-to-bowel anastomoses or pancreatic anastomoses. Extra fluid that distributes in the interstitial space can actually compromise these anastomoses and cause them to break down, which could lead to some catastrophic problems with the repair job itself or abdominal fluid leaks. And so that's definitely something that you wish to avoid, and those are patients that actually might be both fluid responsive and fluid intolerant at the same time. Patients where brain edema is a problem may also cause some pause to think about whether you want to give fluids all the time to those kind of patients. And finally, intra-abdominal hypertension and abdominal compartment syndromes are often caused by excessive fluid that's being leaked either into the peritoneal cavity or by just interstitial swelling of the bowel contents. And those are certainly patients where further problems might arise by giving additional fluids. Now here's the hard part, and it's hard to sort of discuss this without specific situations. So you have someone who needs resuscitation and everything's pointing to the fact that fluids are the way to go, and at the same time they're fluid intolerant. So what do you do then? Well, in those cases you might cheat a little bit and try to redistribute some of the fluid from the venous capacitance vessels centrally with some judicious use of vasopressors, or this also might be a patient where you might be able to recruit a little bit more cardiac function and heart rate by use of an inotrope. But it's hard to make any great categorical pronouncements about what the right thing to do is. You have to take those case by case. So to summarize, fluid management in shock is part of a dynamic where you recognize that there's a problem in either oxygen delivery or blood pressure, and you strive to improve both of them by working on a common factor called cardiac output, and in doing so by actually improving the position on the Starling curve by the use of fluids. As you resuscitate a patient, you have to consider the issue of fluid responsiveness as well as the issue of fluid tolerance. In most cases, as long as you're treating the underlying cause, be it an infection, an allergic reaction, etc., often you Having said that, the next talk will look at decisions on using inotropes and vasopressors and when you make those decisions and pull those triggers. Thank you.